So we can, I think that there is a lot of things to discuss about. So is there any question from the audience, or we, Livio?
Question to Renato. Thank you for your nice presentation. I didn't know about some of your slides that you have presented, but I was impressed about the experiment performed using the aromatase inhibitor in comparison with the other experiment where women were treated with androgens. So there were differences that are consistent with the role of estrogens. So if you have a comment on this, because I have perceived today that the key is androgens, but androgens are just the substrate for estrogens that are demonstrated to be anti-apoptotic and proliferative factors. So if you have a comment on this.
It's very difficult to conclude about the why these results were obtained. Maybe there are other factors that we didn't see. What I say about, or I could say about the use of aromatase inhibitors, that it's at least controversial. So for poor responders, so we can manipulate the production of estrogen, so it decline the estradiol production, but the amount of androgens that are produced is difficult to establish. I didn't have time to criticize that, but I would like to just to add that if we want to improve the intra-ovarian androgen concentration, we don't have the good option. But administering LH activity, we are targeting the follicles, the theca cell mass. And the problem is that these patients have a reduced theca cell mass. So we can improve the dose of LH availability, but the resulting production of androgen is low because there are few follicles. And the same would be true to aromatase inhibition. So I would tend to privilege maybe the administration of androgens, systemic administration of androgens that are not dependent on the theca cell mass.
Any other questions at the moment?
I have a comment to...
Yeah, please.
Yeah, I would like to congratulate my friend Antonio for this very clever idea and project. Of course, we are interested in LH administration, extended LH administration, maybe through androgen production. We are doing something to the follicles that are very good. But we cannot forget about FSH. The first thing is, why in your prospective study you don't add an arm, study arm with chronic FSH administration too? So one side LH, the other side FSH, and the third arm, a combination of both. Because otherwise you could be criticized on that. Why not FSH? Because these follicles are sensitive to androgens, okay, to LH, okay, but they are even more sensitive to FSH, or at least as effective than LH. The models you used, I would like to have your opinion on that. When you suppress for a long time FSH, the mean follicle sizes will be reduced. So AMH is produced by the small follicles, but the most producing follicles are not the under 2 millimeter follicles, are the 3, 4, even 5 follicles. These follicles are not there when you suppress for a long time FSH. Though maybe it's not a direct effect of the lack of gonadotropins, but just your impairing the folliculogenesis. So the follicles are just tiny, they are there. They are not producing AMH, much AMH anymore, but they are there. So when you give FSH to this follicle for 2 months, you get the AMH rise too, not only LH. So we need to consider to come back with FSH, reinvent the wheel, and maybe envision another future, not only with LH, but with FSH.
Thank you. Yeah, I thought about a combination of LH and FSH, but for practical, there are many aspects. The first one is that, well, when you give FSH to women, you will induce the final growth of follicles. Yeah, no, I mean, you have to check this lady. While if you give LH, you are on a safe side. Believe me or not, you can give LH to women, you will have nothing happens. I can tell you, we have given LH to normal cycling women, she will continue to menstruate regularly. Okay, so I was thinking to a therapy that will make patients and doctors free from any medical examination or visit, you know. You can give, once we will prove this, you can give the therapy and you can say to the patient, come back in 2 months. That's a practical reason. The other one is that if, again, if you look at nature, hypo conditions, sometimes you have women, very often, you have women with secondary amenorrhea, but with an FSH which is quite normal, 3.4, 4, the LH is decreased. What is helping doctors in diagnosing hypothalamic amenorrhea is LH and not FSH. So my personal opinion is that the ovary needs some FSH, which is just a perfume of FSH, and the job is done. What can change the story is the variability in LH. Again, LH may induce polycystic ovary. We know for sure. We have, again, some experiment. You know that we have some iatrogenic polycystic ovary condition. Women who take anti-epileptic drugs, they are normal, they take the anti-epileptic drugs and they develop PCOS because the LH increases. So I'm not aware of any similar activity of FSH. That's why my attention was focused on the LH. The LH is what is starting puberty, it's not FSH.
I agree with you, but there is a threshold for FSH. Of course, the main feature of hypothalamic amenorrhea, they don't ovulate, so they don't have follicle growth. So the circulating FSH that you dose is not effective, okay? So you cannot just say that the problem is the lack of LH. The FSH is not acting either, even if you have quantity in the blood that is superior. So why not considering, go back to my question, I'm very, okay, so push. Why not considering FSH2? Of course, you're gonna have some cysts. These patients are not endowed with many follicles, so they have formed one cyst here, one there, and then the cyst goes out, and everything will be okay. But at the end of the day, the preanthers will be stimulated even better.
Renato, I fully agree with you. I mean, FSH is fundamental. The point is, again, that we now need a proof of concept study. Probably our study will bring negative conclusions, probably, but if it will bring some positive conclusions, I think we are changing everything. We are starting a new era, and with a combination of drugs, of doses, I mean, we are changing really everything. We will see.
We could combine everything.
Yeah. Yeah.
So may I ask a question meanwhile? You have the mic already? Please go ahead.
Yes, may I?
Sure, yeah, please.
Yeah, all right. So just a comment on this very interesting point about combining FSH and LH. I think it's important to use at the right level both. As Antonio is a co-author of us, we have an hypothesis that excessive FSH activity can compromise oocyte quality because it also regulates oocyte cumulus communication. Well, it does. According to David Albertini, published in 2004, it decreases transzonal processes that are bridges that links cumulus cells to the oocyte. It was demonstrated by the knockout model and also by treatment with ECG. The paper is published in 2004 and Molecular Reproduction Development, and it deserves more attention. So that's play carefully with FSH. Regarding the utilization of preantral gonadotropin action, in fact, this is not news. People working on animal models, first of all, GH has been used in this regard, and I believe it hasn't been very effective in the human field because we usually combine GH with FSH, and then it's too late because we need an interval for the release of IGF-1 from the liver. It takes at least 1 week, at least in animal models. But the idea is exactly that, to increase responsiveness to FSH, to increase the expression of FSH receptor. So this hypothesis, this strategy has been around for years. And also it's very nice that you pointed out the utility of the LH priming, confirming Maria Pia Ferraretti's paper back in 2014. And also we've just published, and as I said this morning, it's really interesting because it doesn't change only the number of oocytes and the powerfulness of recruitment, but also oocyte quality. So we're now very curious to understand how LH priming can also improve oocyte quality. Thank you.
Thank you.
Just a comment on your, not sure about this toxicity of FSH. At least with our models of stimulation, we are just increasing FSH doses as much as we can, and we're not doing any damage to the follicle, neither the oocyte. So maybe for a long time, we don't have real data in women on that, but it could be reasonable to give it a try, okay? Give a try to FSH as well as to LH for improving the folliculogenesis of this defective ovarian function women. This is my modest opinion on that. I think it's perspective only. We have been, these slides were prepared 5 years ago already, so I didn't start anything, so I'm not very well placed to respond to your questions about the augmented folliculogenesis concept and these boluses of FSH, but I'm doing some patients, random patients, who had problems with ovarian function, and when I give FSH and I stop the FSH treatment and I give it again, second or third cycle will be much better in terms of number of follicles. I'm not talking about quality of eggs, and because the ovarian aging and the ovarian insufficiency, unfortunately, touches also the quality aspect that we are not able yet to resolve.
Can I ask a question? So, I mean, before the question, I'd really like to congratulate the both of you. I mean, just like Carlo, I started with reading your papers. You're both, out of the box thinkers, a lot of, novelties, and today was inspiring. So, just to say the devil's advocate or to discuss further. So, would you agree that a woman with premature ovarian insufficiency still has thousands of follicles, and her FSH is like high every single day, then if FSH works that way, wouldn't you expect to see her growing, say, 10 follicles once in a while, every few
Yeah,
months?
I know. The same thing happens to the LH levels. So it's not it's a bitropic elevation of this was shown very. So the ovarian insufficiency, there is a higher levels of FSH and LH, but the exogenous administration may be the game changer, I think. And the androgen treatment should be combined to this as sensitizers to FSH. So I'm not sure. I think you're right. In some patients, it's not possible to treat this patient with this approach. But in patients, we have just an elevation of FSH, but not much, not as high as that. And maybe LH too. We can give LH too. Why not? I'm not against that. But I think we need to think about giving FSH as in combination with FSH sensitizers like androgens. This is the one option to see. Let's see what's happening at the end of the day.
Women enter menopause, I'm talking about physiological menopause, with 1,000, 2,000, 3,000 primordial follicles still being there. But you may agree, I mean, if physiologically FSH goes up because there's nothing there, probably we're talking here about 1,000 of abnormal primordial follicles.
Or maybe we need a different size, like in between still.
Yeah.
Antonio, just practical questions, because sometimes we run the risk that very good ideas I don't give the maximum result because we don't have the possibility to do real dose-finding studies in animal model. We go straight to the point. So you start with 150 every second day. In the second case, you did the same. In the trial, you are proposing 187 per day.
Yeah.
Is it just because you started the increase in LH levels, and do you think that it makes sense to give twice per day, or
Yeah. So
how did you reach this?
Yeah, the dose was reached just according to personal experience. But then when we planned the study, we had as a first step to test the proof of concept. Then, if we find something, the second step will be the dose finding study. The dose of LH is split in two. One in the morning, 112, and 75 in the evening. And the reason behind this is that we want to resemble some pulsatile exposure. And this because in the last few years, I've tried with HCG, not small doses, but I give the full dose of HCG and nothing was there. So my idea is that it's not only important the dose, but the pulsatile exposure of the ovary to LH.
Thank you, Antonio.
So before we finish, there's one online question, actually two online questions. I think you answered one already, it's a theory. So can we apply extended LH to women with low reserve? So that's...
We should escape from women with a low number of primordial follicles. I mean, the candidate patient to augmented FSH or extended LH administration are those patients who have a good or acceptable pool of primordial follicles, but for some reasons they have a poor rate of progression of primordial follicles to the antral stage. If the reason of a poor ovarian reserve is the exhaustion of the ovary, there's nothing to do there, I suppose. Okay. Can you agree?
Yeah, I would like to respond to your question, Carlo, about the dose and your answer, Antonio. Do you think that we need to give LH many times a day? But yeah, but ACG is has a long half-life. So the follicles follicle cells will be exposed to LH activity chronically with ACG. And with just one shot of recombinant LH in the evening, during stimulation, classical stimulation, we have just one shot. So you have a pulse, and then during the other 20 hours, we don't have nothing. So how we cope with that? But this is the overall question here, not only about your protocol. Should we use recombinant LH 3 times, 4 times a day it will be better, or ACG? What is the best way to?
The best is to resemble what happens in nature. Yeah. So, but I mean, I showed you the study in which authors, French colleagues, they used the pulsatile generator for 3 months, and so they gave pulses of LH, and they showed an increase in MH, 1.6 to 2. That's good. I mean, for me, it's a very, it's a pump. Probably that's the best way. But at least in Italy, we do not have pump anymore. But I mean, what we want to show, again, is the proof of concept. Then you will try to find the best way.
All right, so I think for the sake of time, we need to conclude the session. There was one, but we're out of time and they have to leave. The other one was, if you want to give a short answer. So do you do anything to bring down the LH level of a patient with PCOS, or do you mind that? A patient with PCOS, high LH, so you're starting her an IVF cycle, would you do anything about it? So not at the moment. All right. Thank you so much. It was a wonderful session.
Thank you so much.